You're supposed to be in class at 5 o'clock?
Yeah, I have class from 4 to 7.
All right. Hi, everybody.
Hey there, Rick.
How are we doing tonight? How many do we have? Can I tell? Do we
Yeah.
have a quorum?
Seven of us.
Nice. Wow, I saw that introduction for what you want to talk about tonight, and I wondered how long you want to take to talk about this and get a sense of what you want to take away. And I think exercise is a really good, because I've been dealing with that in a very specific way, from a sports medicine standpoint. But I'd also like to, answer any questions that anybody has just about COVID, and where we are with it in our county and our state. And, I would like to get some feedback also from people who might have some, experiences, because it's California, we don't have a lot of experience. It's not as prevalent as it is in some other places.
What are you getting from any higher level conversations at the university relative to not this spring but next fall?
Next fall looks really good. Yeah, and whether it's a hybrid of some percentage, of how much they're willing to fill the spaces. And I was actually hoping for some activity for the spring, just because of what I'm predicting to be a pretty, pretty mild, influenza year, because we're all wearing our masks, and we're not going anywhere. We're washing our hands. Like, it's amazing how germ sort of, not really phobic, but sort of minded we are now because of this. And so if we can thank, COVID for anything, I gave a talk to one of our teams this morning, and I said, is there anything good that came out of COVID for any of you? And like I said, me neither. It's really been nothing, but there's been a few positive things. We are the most sort of immunology, virology educated population now ever. People have a certain basic understanding of how viruses work, and that's great, I guess. But it has taught people about how to stay well, I think. And that's my main criticism of the media. When I watch the news, there's all this talk about distancing and washing and wearing masks, and what mask is good and what mask isn't good, and where you can go and where you can't go, and what's open and what's closed. But there's nothing, and I mean nothing about how to stay well, how to be well, and how to for when you get this virus or any respiratory virus. And this is what bugs me a lot. Certainly there was a very solid study that actually was put out by one of the Harvard, medical staff, that talked about vitamin D, and the title of the paper was "Vitamin D: The Low-Hanging Fruit." And what that means is, like, this isn't something that's some fancy drug that's sold by a pharmaceutical industry. You can get vitamin D anywhere. And what they did in retrospect was look at the vitamin D levels of people who did well or didn't do well. And once again, it's an association, but if your vitamin Ds are well above normal and in the 50 and above range, there's a very low chance of having the bad outcome from this virus. And if you think about what vitamin D does, it's an immune modulating hormone in a way. And so, vitamin D is good for your bones and calcium and all that. But in the last 10 years, vitamin D has become this star of understanding of gene expression. There's something like 3,000 vitamin D receptors in your DNA, and it's this immune modulating entity. So vitamin D is in a good range. That's what they call a cytokine storm, or that inflammatory storm that's really killing people. This virus is unique in that way, is that when they do bronchoscopies, for instance, if someone's in the hospital and their lungs aren't doing well, and they put the bronchoscope down there and they take samples looking for any kind of virus, they don't grow anything, but they they see this massive inflammatory response, and that's what's killing people. And that's probably what this little talk can be about, because the question is, if you get COVID, what are some of the residual sort of signs of inflammation in some of your body's tissues, namely cardiac, maybe even brain, definitely lung. And what are some of the residual side effects that can be a limitation for you, or even make exercise kind of dangerous? And so I hope I didn't scare you with that, because I don't think exercise is going to be dangerous for many, but I think for some people, the side effect of this virus is this persistent inflammatory sort of scar-like existence. And so yeah, so what we're doing, just to fill you in with what we're doing with sort of young and healthy people, and what I mean is intercollegiate athletes, and this has been discussed at the highest level of sports cardiology, and trying to figure out whether it's safe. And you've probably heard about some of the pediatric systemic, inflammatory conditions that have been very rare, but have been observed, and even some young kids with this. And that was made it to the journals very quickly. But what's also interesting is this possible residual myocarditis. And so when I get, and we have a very few athletes with this, but the standard right now, when someone has a documented COVID case, and there's more people who are having sort of positive COVID tests, but no symptoms whatsoever. But when we have an athlete who has had some symptoms, no matter how mild they were, we're doing a cardiac workup before we clear them to exercise vigorously. And so one of the things we do, which is I'm very proud of, is we do an EKG. And what I mean by proud is, like, when I do pre-participation physical exams, which I've been doing for 15 to 20 years now, I started doing EKGs on all of our incoming athletes. And the reason I did that is because there's a saying in cardiology. It's called, there's no EKG like an old EKG. Because when someone comes up with something, you have an old one to compare it to. And for those of you who have looked at EKGs of athletes, they tend to be kind of strange anyway. And they have some fixed sort of normal abnormals. And what I mean is, some athletes will say, "What are you doing this EKG for?" And I'll say, "Well, I'll tell you why." And I show them something on the screen, and I say, if you walked in, to an ER with this EKG with some chest pain, all the bells and whistles would go off, because it looks like you're having an MI. And so there's this precordial change through the athletic heart that is just normal. So if you have a copy of that when someone comes in, and now what we can do is do an EKG, and if it matches, that's one little box that we've checked off. And I've been sharing that with our conference. We have a working physicians group in the Big West Conference where CSUN is, and I've been sharing that reality with them for a few years now, and they all kind of, they always sort of laugh at me, because there's no real good evidence that it's really effective to do screening EKGs on healthy young people, and they're probably right, because we don't uncover many things. We've uncovered a couple of sort of harmless abnormalities, which they should know about for the future. One of them being WPW, Wolf Parkinson White, which they might not have symptoms from, as a young person, but it's good to know. But for the most part, they're right. But now, I look like a star because I've got these old EKGs on everybody. And so, so that's one thing that we do. And we do this some lab work too. One of them is looking just for the CBC, looking for inflammation. We look at a SED rate, sometimes a C-reactive protein. These are baseline sort of tests for general inflammation. They don't say where the inflammation's coming from. They just say there's some inflammation there. And then we do a troponin I. And a troponin is basically a heart sort of enzyme that comes out of the heart when the heart muscle is stressed. And so this is the first thing we do when someone comes to the ER with some chest pain, is we do these troponins. and see which direction they're going. We'll do it right away, and then we'll do it in a few hours and see if it's going up. And so, so we'll get that test and see if that's normal. So that's one more checkbox. This is all new because there's no evidence that this is absolutely protective, but it's just a little bit of insurance. And then we actually order, an echocardiogram for our athletes as well. And we have a partner with a cardiologist with Northridge Hospital, and he's happy to do that, very easily and quickly for us. And we're just looking for evidence of fluid around the heart, the valve use, how the valve's motion works, how the ventricular wall motion works, et cetera, and make sure there's nothing untoward in that way. And then lastly, what's been tossed around is a cardiac MRI, and that's not something that we're doing. And there's good reason for it, and there's not many people who are doing it. But cardiologists talk about what's the best possible test, and cardiac MRI actually looks at the nature of possible inflammation within the muscle body of the heart. And the problem is anybody who's had just any viral infection, if you do a cardiac MRI, you'll see some inflammation within the myocardial space. And so it's not really specific for this, nor is it predictive of a problem. So, but I suppose if you have one that's absolutely normal, you can be reassured that there's a normal heart going on there. But the presence of some inflammation in the heart muscle isn't all that sort of specific for an indication to keep somebody from exercising necessarily. So we're not doing that one. So that's the heart. But if you sort of do a survey of people from a lot of different ages who have had COVID and look at some of the symptomatology of their life months and months after they've ostensibly, recovered from COVID, you'll see a lot of fatigue, just general fatigue. And the fatigue comes in different ways. Sometimes it's just sort of exercise, tolerance. Sometimes it's mental in their brain, like they just can't, they don't have the mental stamina. And for some people who have some baseline, lung issues, asthma, et cetera, they tend to be getting over it much more slowly. And they're talking about like shortness of breath with what used to be pretty easy things to do, walking up a couple flights of stairs. And these are people who were, previously active, had their COVID infection, got over it, and then they're having some exercise limitations. So anybody who has that, who wants to get back into some vigorous exercise, deserves to have that cardiac workup, in my opinion. Does everybody need it if they want to do some moderate exercise? I think not, because I think that mostly their symptoms will limit them. I'm going to tell you something. I did my first, it was like 2 days ago, I did my first Peloton thing. Anybody out there done Peloton? Like, you'd sign up and you get this person who's like incredibly good looking, incredibly fit, and they're like staring you in the face, and they're yelling and screaming at you and telling you how great you are, and like, I was so, oh my gosh, I was so like enthusiastic about trying to, beat people in this little list on the side of the screen. And, my wife said, man, you look kind of pale. Are you okay? So I don't recommend like getting a Peloton and getting into some competitive situation after you've had COVID. And as the first thing, I think everything as with it is with any sort of viral infection, by the way, there's a recovery. And for some people, the recovery is pretty long. So how would I screen people for like who I should be mostly careful with? And that's the main question, is like, what sort of group do you fall into to be at risk for having some of these either difficult times or even really difficult time, dangerous times? And I think it's a matter of who has the high level of baseline inflammatory sort of disease. definitely people with any autoimmune disorders. Why is that? Because these people tend to have this ongoing inflammation that gets into a lot of their systems, heart, lung, etc. And so having a bad outcome from a COVID, infection tend to be those people with baseline inflammation and baseline, heart conditions. But this is the unique thing about this virus, people, is like, it's not like influenza where, if you're a young person, you get influenza, you got influenza and you feel awful and you take yourself out of the population and you're in your bed, for a week or two. And that's the reason the influenza doesn't spread so easily, because once you get sick, you're out of the commission until you're less infectious.
Do you get a sense of whether or not our students are, I mean, they're obviously not on campus, but the flu shot's free for them on campus. Do you get any sense that the numbers are down for flu shots?
We're encouraging flu shots this year, and let me just say it's not free necessarily. The policy is that it's if you don't have any insurance, they'll find a way for you to get it for free. If you have some insurance, they're going to charge you. But we don't have an unlimited supply of flu vaccination at in our pharmacy. So we're mostly encouraging people to go, to the CVS's, to the Rite Aids, to go get it there. But we have it here in case people need it. We do. We're vaccinating our two basketball teams. I give a little talk. I don't want to get off too far on a tangent here, but I give a little talk about the flu vaccine to our athletes. It's called What the Flu Vaccine Is and What the Flu Vaccine Isn't. Because there's a lot of belief surrounding what the flu shot is. And it's important to understand that it's either 3 or 4 or, trivalent or quadrivalent vaccination. So basically there's 4 things in that vaccine. And these are all sort of different strains of influenza that they do a little calculation, estimation of what happened the year before. They put it into a vaccine, and that's what you're getting the vaccine for, those things. That's it. It's not some shot to keep you well. It's not going to keep you from getting a bad cold, absolutely. And there's this beliefs thing that says, I always get my flu shot because it keeps me well, or I never get a flu shot because it makes me sick. You hear that a lot. And it might make you sick. The reason is because it's inciting an immune response on purpose. And it's on purpose. So if you feel bad, it's your immune system revved up to fight off that flu shot. When I have people get flu shots, one of my main concerns is that they feel good and they're well when they get it, because I don't think it's all revved up fighting off some other infection like a cold, and then you throw a flu shot on top of that. I'm against that. So so that's the flu shot. So is the flu shot, my prediction is based on what happened in the Southern Hemisphere this year, because what they saw in the Southern Hemisphere, which is coming out of their, we're just coming out of summer, they're just coming out of winter, right? And they had influenza numbers that were about 1/5 of what it usually is. And it's because of COVID, they're not intermingling. And so if we keep our distance this winter, chances are we'll have a similar result. Yeah, you've seen a lot of commercials, a lot of stuff in the media from medical establishments really encouraging the flu vaccination this year, and that's mostly, it's less for it's important. Certainly, it's important to try and avoid getting influenza, but it's a question of our manpower and our capacity to handle a wave of COVID in our hospitals and influenza. So far in California, we've done quite well. It's been a steady sort of wave. It's been this steady wave of COVID in California, whereas in other parts of the country, you've had these waves where it's come close to, come close to overwhelming some of the medical establishments. But we've been quite, fortunate in California, especially some of the counties that are less sort of densely populated. But it's important to know that influenza is not a coronavirus, and vice versa. And just to discuss some of the testing challenges for this, coronavirus is a brand or a certain type of virus, and so these coronaviruses are RNA viruses. And RNA viruses are a little different from other types of DNA type viruses, but you might have been exposed to some RNA respiratory viruses in the past, and it's possible that those infections have given you a little bit of immunity to this coronavirus. And so, because there's some cross-reactivity of some of the antigens on these surfaces, and so that's possibly a good thing. There's some coronaviruses that just cause a common cold, and you get it, and you get over it. As you know, historically, we had, in early 2000s and then 2009, we had two previous coronaviruses, the SARS and the MERS, and they were in other countries, and they never quite made it here. And the reason is they kind of died out. They made people sicker, and they didn't transmit as easily as this COVID-19, as we call it. And as you know, they call it COVID-19 because it was discovered in 2019. The 19, that's just what that means. It's actually SARS-CoV-2 is what the virologists call it. But again, the reason this virus is so unique is that for a few reasons. One, it can cause almost no symptoms in young people or healthy people, or it can kill somebody. That's the hard part about this one. And then the other thing is, again, the testing. Remember the testing? Remember how I said you might have been exposed to a coronavirus in the past. That makes testing for for antibodies really maybe not so useful, because you might have some antibodies from a past infection of a coronavirus, and it might not be specific. They're getting better laboratory-wise at the specificity for the COVID-19 virus, but it makes testing complicated, and we're going in circles, from an NCAA standpoint and a competition standpoint, is what kind of testing and how frequent it needs to be. As you probably know, the NBA did a very successful, season and postseason by living in bubbles. And I was so impressed that these, they convince these millionaires to isolate themselves basically. And yeah, it was Disneyland, but it gets real tiring. But that is what we're doing in essence with our athletes too on campus. We're having them live in the dorms. They live in their own dorm suite. They don't even have roommates. They have food that's on campus. They go to practice. They go to class. And it's really, from a mental health standpoint, it's very stressful. And I know that you all and all of us have had a certain amount of stress over this separation from each other, and I think that we as human beings were meant to live in community, to share our space with each other, to be with each other, especially our families and friends, etc. So this has been rough because mental health has a sort of an association of immune sort of stress too, doesn't it? And so people's immune systems are also stressed because of the social stress, and I think that's been a problem. But I think everybody's given it a try. I think, in my opinion, we're probably, we're about 9 months into it, and I think we've got another 9 months to go before we can say that we can get back to normal. That's why I'm hopeful. If you look back to 1918 and the Spanish flu, that was about a 2-year ordeal. Obviously, it was a different time and space. They didn't have social media, but they did know about masks. They knew about the importance of getting out in the sun. If you look at some of the old sort of posters, from the flu epidemic of 1918, they did all the things that we were doing now. They were encouraging people to wear masks. They were actually encouraging people to stay home. They were closing some businesses. And there's one thing they said, get out, outside and take a walk every day and get out in the sun. That was really interesting, because even back then the sun was thought to be a healthy thing. So COVID and exercise. I think that almost covers it, because I think people, when they had COVID, have to go and talk to their doctors about entering into a vigorous exercise program. But what I'm emphasizing now is a gradual return, and symptoms and limitations of those things will probably be the best markers. There's no data right now on sort of bad cases of people dropping dead, when they've had a fairly average case of COVID and going out and doing exercise that they used to do, sort of gradually leading up to that. There's no evidence of that whatsoever. So I'm not, I don't think we should be afraid of it, but we're just being on the safe side with our athletes.
I was actually kind of surprised that given we're essentially virtual, with very few classes, I was surprised that they brought the athletes back on campus. I thought that, at least politically, that we would have to hold off on that until enough of a student population that said, okay, it was that whole student athlete versus athlete student argument. Yeah. I was surprised that we brought them back on.
I was surprised too. I think that we've been in a constant, and I mean continual conversation with the public health officials in LA County Department of Public Health.
Yeah, especially since we're so high still, right?
Right. This county is rough. And so developing policy has been almost impossible in the state of California, because we have all these universities in all these different counties with all these different, colors now. So we have purple, we have red, we have orange. And so that's from worst to better. And then there's green. And so nobody's green. And, but getting back to the political and the political and sort of the economic decision to play basketball. And that was a decision that was made pretty early. It was in the summertime. And it was absolutely clear that all the fall sports were going to be canceled. And then there was this hope that maybe these sports could be played in the springtime. And that is currently being discussed. But if we have a campus that's not populated, that's going to be very complicated for us to have other athletes on campus and justify that. With all the other students who are not allowed here. And there's a lot of people here who have good reason to be here too. We have people in kinesiology who depend on, the laboratory situation to gain their sort of, their education and their degrees. We have people in entertainment and film who have projects that could be happening on campus. And everybody's vying for that sort of, opportunity to continue their programs. And there's an emergency operations committee, on which I communicate with all the time. Our student health director is actually on that committee, and I actually had to present to them. I'm getting better at the Zoom presentations. Like, you notice I got the light now, so that's one of those musts nowadays. You got to have the Zoom light. And so, I think that when they looked at basketball and they made the concession for football, if you look at sports, right, college sports, you can turn on football all day Saturday now and see that it's thriving. And there's actually now we have some retrospective, studies on the incidence of COVID in football and seeing what positions might have the higher, risk. And so obviously it's your nose guard and your center that are just breathing down each other multiple times. And when they put that in the context of the CDC's recommendations of not coming in close contact with somebody closer than 6 feet for more than 15 minutes, right? That's what the CDC specifies. And what's really interesting about that, and people always try and find an angle, right? And so So I actually someone did this study once about football, and they said if you ever watch I don't know if any of you like football, and you sit there for the whole game, that's cool. But next time you watch a football game, get out your stopwatch or put it on your phone, and start the stopwatch when they say hike, and then stop it when the play is down, and then add up all the time, because you'll sit there for 4 hours through lots of commercials, a lot of commentary, a lot of slow-mo, a lot of this, a lot of that, but you'll come up with 6 minutes of actual hike down. So it's an amazing sport, brings in lots of money, right? And it's a very, very important industry and there's a lot of people's lives that depend on this industry. When you think about public health, and turning off an industry like that, it's a big deal. And so when you look at the next big sport in college, which is basketball, you have a tournament that they canceled this recently in March, and the cost, the losses in revenue for that, for colleges, because it's shared over the Division I sort of playing field, even though a lot of schools that make it there do real well, but the NCAA and a lot of colleges share in the huge, billions of dollars of revenue. So to cancel something like that, which they would do if they had to, and the question is, like, is it unsafe to have these young people play sports against each other in a controlled environment? And the answer is, it's actually really very safe. And when you think about, is it safe for these young people to even be on campus? That's the number one question that we ask, is like, is it okay? Are we going to play basketball? That's fine, but is it safe? And if these athletes, choose to live on campus and sort of live in a bubble that way, it's extremely safe. And so we have sorry.
Are they actually set for playing a season this year then?
Yeah, schedule is
Big West.
Yes, the Big West has a schedule that's set, and it's going to start in January. There's a few games that are preseason, that are pre-conference games. Some of the stipulations for this season are some really smart changes in the conference, and that is that we have 5 Cal State schools and 5 UC schools in our conference, plus University of Hawaii. And what all the members have agreed to do was to, one, travel by bus as much as possible, except for Hawaii, and then because everybody else is in California. And then lastly, what we're going to have is each team will travel to a host university and play 2 games. They'll play on Friday and Saturday. So when they would usually spread out the 2 games for each school, they'll play both of those games on a Friday and Saturday. So there's great decrease in the amount of travel, and then decrease the amount of exposure, because they'll be exposed to the same players the very next day. The same referees will ref both games. So that's a really good idea. And then we have a few games preseason. They start around Thanksgiving, and they're just all bus games. Some people will come here, and we have a few that are away. It's unfortunate. Our basketball team, we're going to play. The original schedule was for our men's basketball to play Villanova this fall, and they won the NCAA championship a few years ago. That would have been a great trip for our young men, but that one got canceled.
No, men and women are on campus then.
Yes, they are. Yes, they are. And so so there's been a huge amount of questions, what can happen with the spring, and all I know is that unless we can open up other aspects of our campus, it would be very hard to rationalize having a bunch of athletes on campus practicing. But currently the Big West Conference hasn't made any statements about what's going to happen with the other other sports, because we're just dealing with 30 athletes right now, but we have 300 athletes. So like that's a big difference to have all these other athletes want to be on campus. And there was talk about having, some sort of semblance of seasons for all these sports that were missed, in the fall, to have them in the spring. And you could do it. It's a manpower issue for the university, because you have to have people taking care of those events. It's an event issue. But we have the space. It's just outdoor space sometimes anyway.
So how have we justified basketball and not the other quote unquote spring sports?
Well, I think first of all, basketball is a winter sport, and it was decided at the NCAA level, both medically, beforehand, that we could let's play basketball and see how it goes. And when I presented that, when the idea was presented on a national way, because it is a national decision, because it came out of the NCAA and their medical wing. And when they said that, I said, look at people, we have to be successful at this. And I present that to the players, because it's
just
hard.
Just like the NBA in that
Yeah,
respect.
I mean, and it's hard at this age. I have young people aren't social distancing, period. And so like that's just not part of it's not in their sort of prefrontal cortex yet to like even think about that. So I think that having them live on campus, has been the smartest thing to do, since there's space. And they would be here anyway, but I think it gives us a chance to pick a sport that represents an industry that feeds a lot of people, and try to keep that running. So I'm not against that at all, and I think if we can be successful, that'll open up space for other sports to start playing, especially the outdoor sports, right? Because outdoor is really different from indoor, and it took us, it took my sort of a 10-phase thing that I wrote for the conference to inch back inside, because we were actually doing some conditioning outside, where the strength and conditioning team, and then finally we allowed them to come inside, run through some plays, and then we moved to actual full practice inside, which is where we're at.
I mean, I know I had one of the he's actually helping volunteer the strength and conditioning right now. And they're, most of it's back into that strength and conditioning room, which is smaller, because there was conversation about using our KIN 200 room, which is bigger, and I think allows for more space than the downstairs room. But I mean, it got into the politics there again of, okay, you're going to use our equipment. What kind of reimbursement are we going to get for the wear and tear, et cetera? So I don't know where those conversations are.
Right, but if the person that you're talking about has been one of our sort of interns, as we call them, with strengthening.
Walter,
and the reason I know some of these names is because I'm ordering all the COVID testing, and so that's what I do for a couple hours. And then I have to review them too. So like, this is what I do for a living now. Basically order COVID tests, because anybody who's coming in contact with the athletes are part of that tier 1. So that's what they call it. So tier 1, tier 2, and tier 3. And so, if you're part of an event, just setting up an event and you're not having any of that personal contact, then you're tier 3. And there's tier 2 is basically people who are handling some of the equipment, caring for it, but not necessarily having connections with the athletes directly. But tier 1 are those athletic trainers, the coaches, and this strength and performance staff. And so there's a lot of people, and that that's something that was from a budget standpoint was had to be wrestled with, and is currently being wrestled with by a lot of universities too, because we got a commitment from our president to be able to do that with these sports and be able to test, because we're doing one test on everybody right now per week.
One per week.
But when the season starts, all the universities have agreed to 3 tests per week. So that's a lot of tests. It's expensive.
What's each test run? What's the
Well,
cost?
we're actually getting the machines at our health center. Right now, if you send a PCR, which is a polymerase chain reaction, that's a piece of genetic, material in your nose. And that's the standard, by the way, for testing. And that is $100 with Quest LabCorp. When it first came out, it was 69, and there was they saw that they could make a little more, so it became 100. But there's another test called an antigen test, and an antigen test works like this. It's not looking for the DNA in your nose. It's looking for little pieces of the virus wall. It could be these spike proteins. It could be some of these other proteins, and it presents that, to a gas chromatography sort of slide, and it presents some antibodies that they know of, and if that is positive, then that antigen, which is part of the virus, is thought to be present in your nose. It's much more reliable in someone who has some symptoms. So it's a great test for someone who's symptomatic. And if you've ever been to the doctor and you had like a sore throat and they swabbed your throat for strep throat, you're like, okay, here goes. And they do that back there on your tonsils. And they say, it takes 15 minutes. And it's a similar test. It's a similar type of test in that if it's positive, it's very reliable. If it's positive, it's very reliable. If it's, you got strep, here's your penicillin, see ya. If it's negative, it's not so reliable. So it's a good test, because if it's positive, you can pull somebody out, start the contact tracing. We've got COVID here, because there's so many symptoms that cross over. It's just a cold. You do this nasal swab. If it's negative, you're still not sure. The person has to isolate, until you get the confirmation that it's not COVID, but there's no proof that it's not. So that's a tough place to be as a clinician, to tell people what to do. Because you like to tell them that it's probably not COVID, but you can't. So they have to isolate.
So if you do turn up a positive test, what's the protocol for the team at this point?
Yeah, the whole team has to quarantine. And so that's why positive positive PCR tests have been cropping up that might be false positive. And it was in the news recently. One of the famous coaches, I think it's the Alabama coach, tested positive on a screening test. There's no symptoms apparently, and then they were able to justify doing sort of 3 PCR tests in a row that were negative to allow him to go back and coach on the sidelines for a Saturday game. So, that's interesting because he's an important character, right? Yeah, exactly. So I don't know, we get to watch ESPN and get that version of the story, and then someone knows the story. Bottom line is, when you have a cohort and one person comes up positive, the whole cohort has to quarantine. And the CDC states that it's 14 days. It's interesting because that's the incubation period for the virus is about 4 days to about 14, even though there's a recent study out saying that it's more like 4 to 7 to 10. But that's where the 14 days comes from. If you have a positive COVID test, and you, by the way, if you got an antigen test, you would have a PCR follow-up test just to confirm that. It's only 10 days. So like if you have it and you're 3 days with no symptoms, you can be back, but it's no less than 10 days. So you could be, feel good after 4 days and you got 3 days, 7 days, hey, I'm back in 7 days. No, you still have to be out 10 days. That's what the CDC recommends. The PCR test is more likely to be positive in a sort of a prodromal fashion. In other words, you won't have any symptoms, but you might become positive. That means you're getting some viruses in your nose, shedding virus. The virus is getting there, replicating, getting out into your nose before you feel sick. The problem with the PCR test is it'll stay positive a long time. It can stay positive for a couple of months after you're well. So if you know you had COVID, there's no more PCR test for you to test you to see if you're, sort of sick again, because until that, until that PCR is negative again, which is interesting because what we're finding is that you can get COVID again. So we thought there was about, we thought at first there was like a 12 to 18 month sort of window of sort of of immunity, but turns out there's a number of cases now in the books of people becoming negative, getting over it, and then getting another case of a positive and same syndrome. So that's bad luck, man. If that's you, it's like I didn't get COVID once, I got it twice anyway. So, and I'm sure they're looking at those people, seeing if they're going to stay well. But yeah, it's really, it's a world.
Bottom line is you anticipate we'll be back on campus in the fall, not this summer, but probably the fall.
Yeah, I expect summer to be the same slow, snail return for. I really hope by summer they'll have the professors come on and sort of start to repopulate the school. We tend to see I think there's only about 5,000 to 8,000 students at summer session anyway. So, that's kind of, they might actually allow for some summer session. We'll see how it goes, but I think we'll have to see. I think we're going to know more when this influenza and winter season is over. I think it'll be more free.
From a personal perspective, do you hear any comments about what they're doing with the old faculty? Like if we open up fully in the fall, is it fully for everybody?
Oh, like you?
Yeah. Personally speaking.
Yeah. Well, I thought you were going to take that deal, but you already have a deal.
I do have that, but I still teach half time.
Right. Yeah, we'll talk about that over coffee sometime. But that's a good question. Is like, because we have in our student health center, we have clinicians who are over 65 who have not been on campus since March the 12th, including our director. And so everything's done virtual, and I don't suspect they'll have people come back unless they have a vaccine available. And that's the vaccine thing is interesting because the vaccines that they're doing for this virus are fairly novel, but just remind you all that
like the flu.
Well, it might not be lasting. One, that's true. Number two, understand there's never been an RNA vaccine made that's successful yet. Because when the SARS and the MERS came up, they worked feverishly to get something going for that, and that was unsuccessful. So they lucked out in the fact that those viruses sort of disappeared and blew away. And so that's why you had those sort of embarrassing comments from our president, and like, hey, this will just magically go away, because he was getting input from people saying this might happen in the same way it happened with these other viruses, but it didn't. And so anybody who was making comments, anytime you decide to comment about anything, you have a chance of being wrong. Well, he was wrong. So, but the reality is, there's another RNA virus that's out there, that they haven't figured out how to make a vaccine to either. It's called HIV, and that is one place where they've been looking for a vaccine for that virus for how long, and doesn't exist. So if they make one, it'll be the first.
Bit harder to spread, that's all. Yeah.
Luckily. And so but it's that's where we are. And I think I wouldn't ever discourage anybody from exercising if they've had a COVID, but I think they should get a clearance from their doctor just to look at them, the whole picture, in terms of look at their inflammatory picture. I think that's what, if I were your doctor, that's what I would look at. It's like, what's your family history of autoimmune disease? What's your history of autoimmune disease? Stuff like that. Because I would walk gingerly through that rehab and sort of reconditioning phase if I had any of that stuff.
I think a lot of us have been pretty fortunate in the sense that we haven't come into contact with very many people who know someone who has
It's very
had it.
true. Even though there's numbers in California and there's tragic stories, it just, the numbers, when you consider the population and how large the population is, it's just not that pervasive. It's really true. So hopefully we can keep it that way.
Yep.
Any questions out there? Anybody out there who knows somebody who has a
No.
question?
But as a student, I'm a little concerned, as in you're talking about how there's going to be vaccines for athletes. And if we were to go back next fall, is this going to be available for students?
Is there going to be what's going to be available for students?
Vaccines?
Oh, the vaccine. I think the vaccine is going to go first. Well, the vaccine isn't going to necessarily go to athletes first. It's going to go to the people who are immune compromised and who are at risk first, which would be old people and people with underlying conditions. The hard part about assessing the safety of vaccination is that all the studies that are being done now are being done in healthy people, healthy young people, right? They're not putting this vaccine into old people and seeing how they do. And so when you create a vaccine, it takes years to do the post-marketing studies and seeing if it's safe and effective with the populations that you're really trying to protect, if that makes sense. I am not one of those people who's ready to put my arm out to get this vaccine first. I'm just not one of those people because I'm not I'm not at high risk for having a bad effect, sort of a bad effect from getting the virus. And two, I don't know if I trust, the people creating the vaccine that much to just take it. And I think the people who are sort of featured in the news articles who are happy to go expose themselves. There's a study in England now of people who are willing to just be, to breathe in some COVID virus now since they've had the first wave of one of these vaccine trial. And I don't know whether that's courageous or just stupid, I just don't know. But I'm not willing to be that or have the people that I love to be that right now. I don't think the virus is that important anyway.
So what he's saying, Jasmine, is you may never see me on campus again.
Oh, no, I am concerned. I have a friend and she's got a lot going on medically and she's concerned. Her husband's a teacher and she was like terrified. They're not giving them options. These teachers are getting pay cuts and on top of that, kind of like being forced to go to school. And when she put it that way, it's like a different perspective. Like we're thinking about us and not about, our older beloved professors and people at risk. So that's something to think about.
I mean, it's odd in a way because, if you think about a lecture situation, you're pretty, you can remove yourself from people. You don't have to be, in that 6-foot space for 15 minutes. And I know that sounds arbitrary, and it is a little bit arbitrary because it could be a little more. I was actually impressed when they said 15 minutes because I thought that was kind of long. But the 6-foot thing we've been talking about for respiratory, transmission from day one. We used to give a talk to the athletes and we'd pull out a 6-foot string and we'd show it to them and he'd say, "This is 6 feet." And that's not from COVID. That's just from how you catch stuff, and teaching sort of contagion and infectious disease. But the vaccine, is interesting. There was the flu shot as an example. We started this talking about what the flu shot is. The UC campuses and the Cal State campuses came out with this blanket statement from who knows where saying, everybody has to get a flu shot, mandatory. You can't, be a student, come back to this campus unless you have a flu shot. And I just said, I don't know if you can really say that, because there's no evidence that the flu shot does anything to protect you from even the flu. You know, the flu shot, even in its best year, like at its very best, is about 30% effective, maybe 40 in the best year ever, right? So it's, you know, it's not a super duper treatment, and to make it mandatory just because it seems like a good idea. So they've actually backed off and then I asked the question, like, okay, well, who's going to be in charge of checking all this? You know, are we in our health center going to be checking this on people? And that question got sent back to the chancellor's office along with some comments from some lawyers, I think. And then they just backed off and says, well, let's just make it a, you know, strong recommendation. And the same thing happened at the UC campuses actually about a month later, is like, they just says, okay, well, we're not going to make it mandatory. We'll just say it's a good idea. So there you go. So the vaccine for COVID isn't going to be here anytime soon necessarily. If it is, it's going to be given to a certain population. And you remember, you know, it's going to be manufactured in one of these developed countries like England, or, you know, they've got some trials in France and the United States. But then the question is, like, how do we distribute this to the world, right? You know, we have this American-centric idea, like, well, you know, there's only 300 million people. If they can have 100 million doses, you know, we can give it here. But like, are we just going to keep it all, or are we going to like let other people have it too? So I think, so it's a global question to ask, who gets it. They should give it to the people who need it, so they can, you know, they can get back into the world too. I think with some confidence, and hopefully it'll work. Hopefully it'll be safe, but there's no guarantees.
I'll keep our fingers crossed.
Yeah, let's do that.
All right.
Is that it? Are we good? 6:01?
That's it.
We made it. Hey, it's great to see you guys.
Learning a little more every time. Thank you, Rick.
All right, you guys, have a good night.
Thank you, Dr. Sletten. Thank you, everyone, for coming.
Thank you.
Good night.
Good night.
Jasmine.
Hi, Jasmine.